Good afternoon. So we're going to move straight into our next session, and I'd like to introduce Sarah Denham, Principal Consultant at Wilmington Healthcare, to present on pathways, not products, how to gain access for innovation through whole system value. So please welcome to the stage Sarah Denham.
Hi everyone, welcome. I'm planning to just give you a bit of an overview of why I've got this mantra that people should talk about patient pathways and not about individual products, and how you can gain traction and interest in the evolving NHS landscape. So first of all, I just want to talk a little bit about all the changes and everything that's going on, because I think to be able to do well in the NHS, you've first of all got to understand it. So I'm sure a lot of you are aware of all the changes that are going on, but one of the biggest things is actually we're now working in an integrated NHS. For the first time, primary care, community care, social care, secondary care in hospitals, but also specialist care in tertiary centres, and mental health are all coming together and working together to try and solve issues in their population in England in 42 different ICSs. So there is, in effect, 68 different NHS systems in the whole of the UK now, because NHS Scotland and Wales have been working in health boards for a number of years, so has Northern Ireland. So really you could say that England are just catching up with the rest of the UK. But I'm going to talk a little bit about the implications of integrated care, because I think it's fundamentally important that everybody understands what it is, what they're trying to achieve, and then how you can hook into their priorities, because if you're not on their page, they don't really want to talk to you. I think there's lots of changes going on in procurement, in NHS supply chain in particular, that companies need to react to. I'm sure you already are, but I'm going to just run through some of the principles of that. You'll have all heard in the press and everything that there's tightening NHS budgets, and cash is a bit tight. Cash has always been a bit tight. It's really how does the NHS make more of what it's got? And I think innovation and technology play a crucial role in that. But fundamentally, what is value? Because it's not always about pounds and pence anymore. It's actually about what does innovation do in, for instance, releasing capacity? Can does your innovation actually release nurses to do something else? Because actually the key thing for the NHS is their workforce and space actually to treat patients. If you can free up that or do more operations in the same bed, that's of huge value to the NHS, because that allows them to get the patients through and out the other side. So I'm going to talk a little bit about that. And then we're also going to talk a little bit about the challenges of service transformation. It's not always easy, but it can be done. So in terms of the road for integration and what's happened, I think my biggest message is that it's an evolution and not a revolution. This has been going on for the last 10 years. People have sometimes said to me, Sarah, it's a bit of a surprise, or is this new ICS, integrated care, going to go away? It's not going away. This is in statute, in law, and the biggest thing that it's actually done is that they've reorganised the organisations, which they've done many times, but the biggest difference this time is they've moved the money to where the organisation goes. So the ICSs hold the money. It's one pot of money. And we'll touch on specialised commissioning has moved and is moving very fast down to ICS systems. It's in joint committees this year. It's full-blown ICSs for the majority, not all, of specialised commissioning, which for medtech, there's a lot of budget and services all wrapped up in specialised commissioning. So basically, we're a year in with ICSs being statutory bodies. They have been functioning in some essence since 2018. but they've been here. So there are variants in the level of maturity, how well they are at doing things than just fighting fire, being able to understand which ones are driving innovation, looking, and different ones have got different priorities in different disease areas. You need to understand it, and you need to understand what's on their agenda and what they're trying to address. But more of that in a little bit. The one big thing that we're waiting for this year is the major condition strategy update. So this is the NHS long-term plan refresh that was rebranded. 6 major conditions. It's going to be the key focus for the next 8 years within the long-term plan. Then there will be no major surprises, possibly some changes to timings because of COVID, but it'll be really interesting. It's due out summer. Now, summer with government can mean a lot of things. We should see it before Christmas, would be my take. In terms of devolution of services and budgets, really messy side this, but I'm just trying to give you an overview of who's involved now at system, because it's system and ICS systems and ICB boards that are making decisions about healthcare services in their geographical area. And you've got to understand them. You've got to know who they are, what their priorities are, and what they're trying to achieve. They have place-based partnerships and provider collaboratives. So these are either, depending on what your product is and where you sit in a patient pathway, if it's primary care, for instance, type 2 diabetes, insulin pumps. Place-based partnerships are being set up in systems looking at bringing together primary care clinicians, secondary care diabetologists, possibly tertiary care as well, the community district nurses, all coming together to look at the diabetes pathway and go, actually, how do we make it integrated? How do we deliver it in the best possible way? So, and they work at place. So they're working at geographical areas, about 500,000 patients, citizens. And so if you've got a new technology that you're wanting to bring out and wanting to get it influenced or commissioned or used, you've got to know where those place-based partnerships are and who sits on them to be able to go and see the right people and have the right conversations. Provider collaboratives tend to be hospitals coming together, and it's different levels for different specialities. If you've got a medical device that's in a rare disease, for instance, there may only be 3 or 4 providers in the country that do that service. They potentially could be working together in a provider collaborative, delivering services at a national level. Or it could be region, NHS England regions. And they'll be and depending on the disease area, will depend on what level it is. But also provider collaboratives, even hospitals are buying things, procuring things together to gain more savings and efficiencies. So understanding who's in a gang, because they are in gangs, is really important. And then the other big thing, guys, is that NHS England is on delegating specialised commissioning in a major way, and this wasn't expected. So last autumn, NHS England said, we don't think ICSs are ready for April 23, and they were like, kicked it in the long grass, wasn't going to happen. And then in February of this year, they put out quite a surprise board meeting minutes from the board that said, yes, we're going live in 6 weeks' time. And we're going to do it in joint committee status, where basically NHS England hold the hands of the ICSs to commission services for 23-24. So not a lot's changing this year. However, 24, most of them, not all of them, will be deemed ready to commission by themselves. And this is for £53 billion worth of budget. So it's not all services, you can look it up, but it clearly states which ones are getting commissioned and delegated down. So the specifications will say the same, but the level at which they're commissioned, the service, will be locally dependent. There is a huge opportunity to ensure that it's commissioned at the right level. I think it's one of the biggest opportunities there's been. There are non-delegated services. So some of the specialised children's services, for instance, aren't getting delegated. They're still going to be run by NHS England. You need to understand this, and you need to know who your audience is, because if you don't, you'll be talking to the wrong people. So the other big thing that's really changing in this integrated world is stakeholders and decision makers. In the NHS long-term plan, it put a clear focus on clinical leadership, helping and supporting systems with what needs to be done. So for instance, you know, Cancer Alliances have been around for a long time. They've maintained their funding. They're carrying on their funding. They have a huge influence on board members and joint committees at system level on what cancer services get commissioned at what level. So if you have a new innovation in a cancer service, you need to know the Cancer Alliances, and you need to know what they're doing, how you can support them, and how your product can really help change the benefits across a pathway. That's what you really need to know. Cardiac clinical networks have been set up. Some are in different states of affairs, but there are these clinical networks that actually you need to understand and influence, make people your friends, because if they champion it, you're far more likely to get innovation put through. Talked a little bit about provider collaboratives. Really important that you know who they're working with, because the days of individual trusts making decisions by themselves is potentially limited. They're working together, so who they're working with, you might not be talking to the right people, or you might need to talk to several more people to get agreement to move forward. So it's about understanding. Same with place-based partnerships, but they tend to be when you've got vertical integration of services, so not everything is delivered by secondary care in hospitals. That's just the other organisation. And then there's particular people at an ICB that are crucial: programme leads, understanding innovation leads. These are the commissioners. These are the people. Sometimes the industry refer to them as peers. I hate the word. It doesn't exist in the NHS. The NHS call themselves commissioners because they commission services. They don't actually pay for anything. It's really understanding who's making the decisions about what level of service are they going to provide for their population. And you could make the argument, are they providing it at the correct level? So we know for a lot of disease in states that what's being commissioned, for instance, for heart valve disease replacement was very low. It was just arbitrary set at 400. And you have to provide the evidence to say there's a huge gap. And that they should be doing something about it, because harm is caused to patients. So it's really about understanding things in a great deal of detail. So that's a little bit of whistle-stop tour about integrated landscape and what's going on, but hopefully food for thought. In terms of procurement, there's a lot going on to changes. I'm sure a lot of you are aware that NHS supply chain is going through a huge restructure at the moment, and changes to the towers and personnel, and there's probably fair to say a lot of people leaving. They were fairly, maybe not that resource heavy to start with. So if you're trying to have conversations with them and wondering why it's taking so long, it's because they're in huge restructure and still led by their chief exec, but there is a lot of changes. So I think just be aware of that. But I think more importantly, be aware of their ambitions on sustainability and what they expect of manufacturers coming to market to help the NHS reach its net carbon target of 0 by 2050. It isn't just a nice to have, guys. You have to do it, and you have to do it very quickly. So by, I think it's 2026, all procurement, you've got to steer how your whole entire supply chain is reducing carbon and offset carbon. So it's all on the website. I've got a bit more detail, but you need to understand that. I think one of the other big things that supply chain, and I think it's really interesting and welcome, is about value-based procurement. It's not all about the actual cost of your innovation, device, product. It's what does it do for the system. So if it, for instance, you know, I can use TAVI as doing transcatheter operations instead of open heart operations, patients, because you're not exposing their body to such trauma, tend not to need ITU beds following their procedure. That frees up capacity. They tend to not stay in hospital half as long as, or if less actually, than somebody who has open heart surgery. That bed that an open heart surgery patient could be used 3 times by a TAVI patient. When the NHS has got such a huge elective backlog and waiting lists are massive, being able to flick from one that was standard of care to another and using an innovation, it's been around, fair to say, for that for quite a long time. We saw NHS England change their commissioning statement in January. That would never have happened pre-COVID because TAVI costs more money than the mechanical device. But it just shows where the NHS is and where their thinking is that people and beds are more important than the actual cash. Now, that is not to say that you guys can just dream up prices and think you can charge whatever you want. That's not the case at all. We're in a taxpayers market, and the NHS has multiple ways in which they drive value. But I think it's really important that you adhere and think about value-based procurement and what that means, and also with your value propositions when you're going to supply chain to get on the list, so at least you can start to sell. Just a bit more about supply chain. For my kind of take, if you guys want to be successful, is that, they're very, so if you compare supply chain with NICE, which is mainly for medicines, but not all, they're doing a lot more medical technology appraisals. They do have dialogue, NICE, with pharma companies, and you can submit and have stuff. But I would say, just as an independent advisor, that supply chain are really open for discussion and collaboration, and they really welcome it. And so if you have transparency with them and open with them and go horizon scanning with them, they'll engage. And I think it's really important. But the big thing, standard national pricing. They hate companies that have one price for one trust and a different one for the other. And it's not acceptable, to be honest. Why should it be? Actually, it's one NHS. You can have national price matrix depending on volume, but you must treat everybody the same. So, and not all companies have clocked this, and those that have are getting a competitive advantage because supply chain want to talk to them, work with them, partner with them. The other thing as well is specialised commissioning sometimes want supply chain to work in partnership with industry, and guess who they want, and guess who supply chain want to talk to? They want to talk to the companies that are having a national pricing matrix, who are delivering on sustainability, who are very transparent in the way in which they do business and want to work with them. So that's my top tips. I think supply resilience is really important. There's a big drive to have stocks in the UK, manufacturing if possible in the UK, all ticks boxes when you're going to be added to the list of suppliers. Obviously all of the conformance assessments have to be done, and everything else. But in terms of the strategic drivers of sustainability, I think it's really important that you've got to be able to tick all of those boxes. There's an awful lot of detail on their website about what they expect, and you've got to put that into your plans and show that how you're delivering against it. And then trusts want to know, can they buy the same thing? Is it good value? But supply chain are doing that for them. Supply chain are there to kind of go, the price has been sorted. I don't have to negotiate. I can just, if it's on the list, I can just go there and I can order. And also I can procure at provider collaborative level or whatever it needs to be. So I think supply chain are going to get bigger and bigger. NHS England are going to force trusts to buy things through supply chain. That's where it's going. So I would say pretty big, important customer for you guys. Don't know how am I doing against time. This isn't working. Thank you. In terms of where the NHS is, cash isn't the biggest player in town because, yes, they're in deficit, a lot of trusts, but if you can help, there is extra money. Electric Recovery Fund is really important. We have gone back to payment by results. It's not all on block contract. There is opportunity. So if hospitals can do more, see more patients, they will get paid more. It is evolving, it's changing, but being able to demonstrate value, and that is releasing capacity, releasing workforce. The days that you can turn around and say, but my medicine or my product will save you X amount of cash. It doesn't, quite frankly. That pot of money never appears. What it will do is it might allow my district nurses to go and see 10 more patients in a week. That's value, because I'm able to do more with the people and the places and the beds that I have. That's the most important thing. Cash is not king. Challenges of service transformation, I think, yes, there is challenges out there. People are really looking at digital technologies, virtual services, virtual wards, doing outpatient appointments virtually, basically trying to get as many people out of hospital as we can so that the people who really need to be in hospital are in hospital. But with these comes unforeseen problems. GPs aren't seeing as many people face to face. If you've got a disease area that really needs a physical examination or somebody to listen to your chest, your lungs, your heart to identify diseases, we've got a bit of a problem. So how can you guys help overcome that? Wearable technology, digital stethoscopes that take out the need for somebody who's a specialist to be able to hear a murmur. All of these different things, you can put technology in the hands of non-medics to be able to identify patients. And often that's the biggest bottleneck, is actually finding people that we should have, or that either don't know that they've got a disease or aren't coming forward or for whatever. But I think there's lots of things. People are really interested, but what they really need to have is something that has been either piloted and tried that could be scaled. So go and pilot and try in a different area. Almost like Blue Peter. Here's one I developed earlier. Preferably endorsed by experts or professional bodies or somebody to kind of go, this might work for you guys, and this is how it could work for you guys in your area, in your population. But really think about that. I think it's, and also it's like the knock-on effects. What does what you're doing over here have upstream and downstream? It's really important to understand that and be able to articulate it in a cohesive way. So, what can MedTech do about this? I think, developing partnerships and relationships with multiple stakeholders that influence decisions is key. And they're not necessarily all in a hospital if that's where you tend to work. You need to understand everybody else that works around you and works in an integrated system, and find them and have conversations with them about their area. Most of the time they don't give a nick. It's 42 different ICSs. They couldn't care less about the next door one unless they're doing better than them, because they want to know where they rank and how far they're off. But you can really, it's about their population and their needs. Developing pathways, not just for cost and clinical effectiveness, but for system effectiveness. It's really, really important. And, invest time in developing your value proposition. Don't do what pharma have done for the last 20 years, which is just talk about clinical benefit, patient benefit, and benefit to clinicians. It's what does it mean to the system. That's the most important bit. And, you know, help and support the NHS. They want to have disruptive technologies brought into the NHS. Be that willing partner and have conversations with the right people. So really, my big thing is that, you know, understanding and influencing the patient pathway will help you engage. You really need to understand what the burden of disease is, what it currently is, what it should be, and what the gap is. Because if you're not finding all your patients, you need to understand why, but you also need to explain that to systems, what's going on, because that's where you can create the case for change, because they're not going to do everything, but, you know, you've got to have a big enough piece in the pie to make a difference. But, you know, heart valve disease, anything that's basically in the long-term plan, guys, you're on a good platform. If it's not, you've got to be slightly creative. And if it releases capacity, if it does other things, then you've got hooks within it. But you've got to align to what the NHS has been asked to do. Because if you don't, I'm afraid there probably isn't that much bandwidth for them to take part. But if you understand the burden of disease, if you can understand what the unmet need is and what exists and where are the bottlenecks in the pathway, and to do that you've got to really understand what's going on. It's not a paper exercise. You've got to get out, you've got to understand, you've got to talk to people. You can then align your solution to what the NHS is trying to achieve and what they're trying to do, and help them and partner them. Because it's all well and good saying, but you're doing it wrong. And it's important to say that and to establish what the gap is. But what they really want is solutions, and they want people to come forward with solutions that have been well thought through, aren't just on product or about the whole pathway. They really couldn't care less about your product, really, unless it's wondrous. And even when it's wondrous, is like the first question they'll ask is, what does it do for me in totality? Because I'm now living in a world in which it's one budget, one integrated care budget. I'm not really just interested in the bit in secondary care by itself, but it might free up other things. And then, you know, ultimately what we're all about is about increasing access for patients universally, not by postcode lottery, so that we have a healthier population of patients. Well, hopefully there won't be patients, but a lot of them are patients that live longer, healthier lives. So I've got a few bits of kind of examples of how I've worked with medtech company, very big medtech company, to actually help to ICSs and commissioners and non-specialists understand what it's like for certain patients with certain disease areas. And we create these patient stories at Wilmington. And why we do this, it's very much like the NHS right care patient scenarios. So it's built on a fictitious patient, but realistic, with a group of experts, clinical experts, to map out what currently happens to a patient with a particular disease. All of the touch points they have with healthcare, social care, everything. And we document it, and we write down all the costs, and we work out all the costs for a GP appointment, for a medication, for a social worker to come in, or a carer to come in 5 days a week, whatever it is, because they've deteriorated. And we follow those patients longitudinally. We then do the optimal pathway, and what happens if they were picked up, there was proactive detection, if patients weren't fobbed off and didn't have to go to the GP 5 times before they were taken seriously, or whatever it is. We map it all out, and it gives people who aren't specialists, which commissioners aren't specialists, guys, the opportunity to understand a little bit about what it is to have that disease. And all committee meetings at a system level always have a patient story presented. They do this bread and butter. So being able to do this creates that sense, we create the case for change, that something different needs to happen. And we do that, and it's all about the implications and costs to patients in the wider system, because it's everything. And they find it really useful. and it can enact change at a national level with all parliamentary groups, with NHS England, but also if you've got field teams out there, you can use it at individual ICSs to think about what are you going to do about this? This type of patient exists. The next thing is, okay, you've understood what that patient looks like, but actually, when I was talking about Blue Peter, and here's one I developed earlier, actually developing exemplar pathways on how, because the big thing is how you do things in the NHS. Developed this again with a group of experts. It was endorsed by most of the Royal Colleges involved in cardiology care. But the big thing was about how do you detect patients? Because actually for certain conditions, the symptoms can often be nondescript. You can think that it's just, oh, I'm getting older, if it's a disease of aging. And patients don't come forwards, or if they do and they're breathless, a GP might think that it's automatically a respiratory condition and not think about listening to their heart. It's the same for heart failure, valve disease, PH. There's lots of disease areas that there's this intermingling of symptoms and they're not easily addressed. We've developed this. ICSs can pick it up, amend it locally, but it's 80% done and it's been endorsed. They love stuff like this, guys. This is what makes their lives easier. You also need to cost it and make it what it means for their population, how many patients do they have in their population, but it can be done and they do like it. The other thing that we sometimes do, and we do quite a lot, is go, okay, that's the pathway, how do you implement it in real life? And we've just done and just published this report looking at using a digital stethoscope with AI in the hands of a pharmacist, community pharmacist, about proactively detecting valve disease. And we found a lot of patients that would have died within 3 years because valve disease has a higher mortality rate at 5 years than all of metastatic cancers. So, we've saved a lot of people's lives. There was 2 critical cases that if our pharmacists hadn't stuck a stethoscope, they would have been dead within weeks. And they've had their operations and they're going to be fine. So it's not only about developing how you do it, but implementing it, showing it can be done. So now we're looking at how can this be scaled, how can it be replicated across the country. And the company that we were working with was eMurmur. I don't know if they're here today, but that was one of the companies that we were working with. So I think it's really interesting what you can do and how you do it, but these are some of the things that we do. And then just in summary, I think industry should focus on pathways and not products. I think you should engage with the right people in the right way and know who all the stakeholders are, and that partnership is really the only way forward. So, we may as well get on with it. Clinical leadership is critical and drives decisions, and you can influence and support your technology and your innovation, but they must believe in it in the first place. So medical science liaisons, I think, is a critical role for industry, is in pharma. Having that peer-to-peer discussion about the technicalities of one device, product or another is very important. ICBs do promote service redesign, and they want to know what works best for their system, in their population, for their needs, and their deprivation, understanding what their population looks like, the deprivation needs. We haven't even touched on inequalities, that's a whole nother talk, and how you can overcome it, and it's equity of access that we really want, not equality, because the same people never get the same results because we all start from different points on the journey of healthcare. And I think that really the big thing is that changing the status quo will require to think differently and do things differently. And where can you look to do things? And where should you go? I think it's important. So I think we're out of time. And that's me. I'm happy to take some questions if we got time, or...
While we change the slides over?
Yeah.
So I was going to say, while we get the next presentation ready, if there's any burning questions in the audience, I'll come out to you and Sarah can answer those while we're get everything lined up for the next session. If you just want to raise your hand. Oh, we've got one here.
Would it be possible to get the slides? Fair enough. Yeah. Okay.
Yeah.
Thank you.
This is not on, is it? It is. You can hear me.
Hi, it's interesting that your example that you just showed was based in community pharmacy, because that's the field that I'm working in at the moment. I'm just wondering if you've got any tips on how to navigate within that field when you've got so many different providers who aren't NHS organisations.
Local pharmacy committees, so the LPC's critical stakeholder within that, and they'll be able to help and support you. And they're really up for things. They're a good bunch, very underutilised.
Well, thank you very much. Oh, one more.
Very quick question. What's your sense of the commitment of the NHS to really driving uptake and use and the scope of the NHS app?
Yeah, so that app is just getting bigger and bigger. So it's here to stay. Digital technology is really at the highest levels of government seen as the way to really unpick some of the NHS's problems, and they're committed to harnessing it. You do need to go through the right regulatory approvals, and DTACT is something that's really important for all apps to go through, and not having different operating systems, and just, everything needs to be integrated as much as we can. It's all right.
Thank you very much.
No problem.